estimated 80,000 across Europe, an estimated 860,000 people use opioids, and just over 500,000 are receiving opioid agonist treatment. But behind of these numbers are not statistics, but people who for decades have been showing up to services to prove they deserve care. Can you imagine for 20 years giving an urine sample every month in some countries like mine under cameras, not as a part of some science, but as a part of control? In other health conditions, a person would simply get a prescription and go to the pharmacy. Can you imagine being tested for 10 different substances, but not for fentanyl, the one drug that now takes more lives than all the drugs combined? The Syria team's monitoring in Ireland found that 51% of people in armed services have been in treatment over than 16 years. 69 of them don't even know what is care plan. 76 of them have never known about complaint mechanisms, often because they believe nothing will change. This is not a recovery, it's a resignation. Then, when treatment starts to feel like surveillance, when people walk into a clinic and feel like their lives being interfered with, we need to stop and ask ourselves, have we forgotten what care means? Should people's autonomy and progress come before any form of control? These are not ethical issues, are clinical, political, and human rights issues. Today, we are here to talk about exactly that, how OAMT services across Europe can move from control to care, from compliance to compassion, from policies that concern us to solutions with us. This webinar is a part of the wider EuroNPUD and ViiV Healthcare initiative, bringing together experts, colleagues, peers, women, clinicians, and policymakers to honestly examining what OAMT has become, and what it should be. We will talk about access, women's health, mental health and rights, because treatment without dignity is not treatment at all. Across Europe, there are inspiring examples, integrated care, peer-led models, innovations in harm reduction, but also deep inequalities between West and East, between men and women, between those who are seen and those who are forgotten. Tonight is not just about problems, it's about solutions shaped by the lived experience. It's about bridging science, policy, and reality, and reminding everyone that the most powerful experts are those who live this experience every day. My name is Christos Anastasiou. I'm honored to moderate tonight's discussion. I coordinate the EuroNPUD Award Literacy and Rights team. And in the past decade, I have worked with people who use drugs, clinicians, and communities across Europe to make treatment more humane, more effective, and more equitable. Like many here, I have seen both sides of the system, its ability to save lives, but also its blind spots. And I believe that when people who live the experience sit alongside with clinicians and policymakers, the conversation changes. It becomes real, it becomes responsible, it becomes possible. So thank you for being here, for caring, for listening, for participating in this new conversation about what OAMT can really be. Let me introduce you the first speaker. The first speaker is Professor Adam Winstock, consultant of psychiatry, traditional medicine specialist, honorary clinician professor of the Institute of Epidemiology and Healthcare, founder of the Global Survey, and internationally recognized expert in substance use, treatment outcomes, and harm reduction. Adam, the floor is yours.
Thank you so much. And I echo your words. My greatest teachers over the years and why I'm still interested in what I do are the people I work with. And although I think over the last decade or so, there has been greater acknowledgement of the role of peers in guiding what treatment should be delivering. I think it is far from what it needs to be. And one of the challenges I have in my day-to-day work is people wanting to do what they've always done before. It's people mistaking historical practice for evidence. And I think one of the ways we shift that is simply asking people who are accessing treatment, hello, what would good look like to you? What things could this service do that would make it better and would make it more useful? But if we ask those questions, then we may have to pay attention to the answers and maybe start doing lots of things we do differently, which is fine, because I think the basics of opiate substitution treatment, which is one tiny bit of the issues that people with opiate dependence have, is really simple, and we can't even get that right, and that breaks my heart. And so increasingly, I'm trying to get my colleagues and the people I work with and the people I train or supervise to embrace the idea of saying to people they work with, I don't know. I think that's a really powerful word. And to also just not forget that even though the system we work in is really shit, the things that patients remember is not the model of care or the organization they work for. It was individuals who basically gave a shit. And that's something that all of us can do. So anyway, I've been prescribing methadone and various other things for 25 years. I've worked as a consultant in the UK and in Australia, and I currently spend an awful lot of time in prison. And one of the things I'm really interested in the moment is pushing forward that idea of shared decision making, which you have in so many other areas of medicine. And for me, that means that you give patients information so they can genuinely make an informed choice over the sort of medication they want. And I know that treatment for OST is a bit like a really rubbish ice cream stall that's basically got vanilla. Maybe if you're lucky, there's strawberry. But I think with Depot now, maybe there's chocolate. But we can be innovative about how we serve those things up. Like you might be able to come to the ice cream shop and have your ice cream there, or you could take it away. Anyway, I think we have to have respect for autonomy around what people want from treatment. And when we piloted the soda tool, which I'll talk about, Matt, who I know is on the call, helped us pilot it. And I think I'm a fairly, liberal, laid back sort of clinician and things. But some of the most powerful feedback we got from people in the pilot was, you know what, there's still a sense when you do this tool that if I'm using on top in treatment, I'm failing. And it was like, oh my God. And so one of the things I always say at virtually every conference I'm at is we have to stop the narrative. If you're using on top, you're failing. It's like, you're in treatment. That's a really good thing. And we have to do all we can to keep you in treatment. Like, it's like people who are on insulin and carry on eating McDonald's. You don't go, you're failing. You just go, well, if you really like McDonald's and you're aware of the risks of eating McDonald's on your liver function or whatever. So it's about respect for where someone is in their journey and what they want from treatment now. And in order to do that, you've got to have people who know what they're talking about. I'd love to go to work with a t-shirt that says, I'm not as stupid as I look, because I can imagine lots of people who have been using drugs for a long time and have been accessing treatment services for a long time. When they meet someone who's like 25, they may just not know very much. I think you have to understand that there are other things people want from treatment other than just substitution. I think we should be offering access to other people who are helpful. And I like to make people accountable for their decisions. So I get people to make sure that their history and their observations are really good. So if they make really dumb decisions, they can be held to account. And I guess for me, the best way of reducing the obvious impower balance between prescriber and patient is about having a shared knowledge base. And I think that's really important. I mean, I'm pretty confident I know all the dealing prices of baggies, teints, half teints, eights across different parts of London because I'm really obsessed by drug prices. And I learn that from the people I talk to. And so I'm thinking, well, you can tell me about drug pricing and dealing and new pipes and things, and I can tell you about treatment. It's an exchange. I was asked to focus on two things. And one of them was women and OST, who, despite the fact they make up about 40% of people who use heroin and maybe about 30% of people in treatment, are massively overlooked in research, policy, and practice. Why? Because most research is done by middle-aged white men on male populations, like very typically of a lot of other areas of medicine. But what it also means is that women are often underrepresented in treatment trials. And I think that's really important because it means that we may underestimate or not spot particular side effects and problems that women have because of their different physiology. And most of the time, when you talk to treatment services around particularly opiate dependence and women, it's all focused on motherhood and the issues of shame and stigma that leads women who might be on opiates who aren't experiencing periods but are still ovulating, who then become pregnant, being really fearful of coming forward because of concerns that social services will be involved and they'll have their baby removed, and fearful of what the impacts of treatment will be. And on top of that, you've obviously got issues of gendered introduction to drugs, sometimes women being controlled by their injecting partner or other forms of coercive control. And then there are higher rates of domestic and sexual violence. And for women often coming to a service where there are both men and women, it's not a safe space for women to talk honestly about some of the issues they have, particularly when there may be men in the room they don't know who may themselves be perpetrators of those issues. And the focus on pregnancy and neonatal withdrawal, which is what researchers are really interested in, I mean, is obviously really important. But actually, if you're not pregnant or having a baby, well, there's a whole bunch of other things that are really important to women and their health that impact on their treatment response, and we just ignore it. And recently, the things that have really flagged up as areas I just hadn't thought enough about was the impact of the menstrual cycle on the drug experience, including craving and relapse risk for women. Really interesting. And also increasingly with an aging treatment population, the whole issues of perimenopause and menopause and how some of those symptoms, hot flushes, irritability, insomnia and things could be mistaken perhaps for opiate withdrawal when you're being inducted onto medication. It might even lead to people being prescribed bigger doses, masking symptoms of HRT. And early HRT access for some people is going to be really important in terms of protecting against cardiovascular risk and kind of osteoporosis, thin bones. And so we need more research and education support in this area. I think there's no point just teaching the odd social worker and the odd drug worker around women and pregnancy. You actually need to teach antenatal services, obstetricians, gynecologists, social workers, drug and alcohol workers, GPs together to support a woman during her journey. And for me, pregnancy is a window of opportunity to engage someone into treatment at a time where they often want the healthiest environment for their baby. But there are so many other challenges that they're having. And to put unnecessary barriers there to get them into treatment is nuts. And you need to do things differently. You may need to induct people who are pregnant on methadone more quickly. Maybe you have to dose them twice a day. As women are getting more pregnant, doses need to go up because there's more of them. Likewise, when women deliver, sometimes suddenly their methadone requirement doses drop. And we need to bust some of the myths that, being on bigger doses of methadone makes it more likely that, my baby's going to get neonatal withdrawal. There is no relationship between the dose of methadone you're on and the frequency or intensity of withdrawal. Harry, sorry. Joey, will you get the dog out? Out, Harry. Sorry, I've got a dog who's hungry. And I think that's really important because what I think we don't do enough on is educating women to understand that the way they have the safest environment is to kind of have an environment where there isn't any cycling in and out of opiate withdrawal. And if doses need to go up, that's absolutely fine. And I mean, oddly, something like buprenorphine or Buvidal, which isn't licensed for treatment in pregnancy, is generally associated, we think, with lower rates of neonatal withdrawal. So I think we need a little bit more research. And I think we need to give women a more evident voice. And that's particularly in prison, where, you know, a young mother who may have a drug problem suddenly gets arrested and there is no opportunity to notify anyone else to kind of pick the kid up for school. I mean, something like that, it's just barbaric. Issues of menstruation and drug effects are really interesting. Um, I mean, the Global Drug Survey, we were kind of interested in the risks of turning up to A&E after you'd used different drugs. And women would have different responses to MDMA depending on where they were in their menstrual cycle. Women were more likely to end up in the A&E department. But I treat quite a lot of people with ADHD, and I see that I need to make dose adjustments for women depending on where they are in their menstrual cycle. And there's a whole bunch of fascinating stuff, some of which people will just get from their lived experience. Well, like 50% of you at least. For example, women tend to become more sensitive to the rewarding effects of alcohol kind of premenstrually. In fact, they also tend to have become more pain sensitive premenstrually as well, which might mean for opiates they need bigger doses. Um, kind of they also tend to kind of crave alcohol more just kind of before ovulation, which is also the time where women are most likely to get euphoriant effects from a drug like cocaine, which can trigger relapse. But it's like, how many people know that or talk about it? I don't think it's done very often. And so I think, particularly for countries where you're thinking about developing and rolling out services, you can't have women added in as an afterthought. You've got to think about what are those barriers, particularly that you need to address to get people in. There's a different pattern of comorbid problems among women, high rates of PTSD and depression, which need to be treated. And then I think having services that specifically address issues of domestic violence and sexual assault and sexual exploitation are really important. Um, I mean, look, probably about 15–20% of people who are dependent on drugs have got underlying ADHD. We could do a better job at treating and diagnosing that. Um, there should be women-only groups where there's a safe space for women. There should be discussions around whether or not your medication needs to be changed throughout your menstrual cycle. As you come into the perimenopause, that's something we should be talking about. And then I think the role of partners is overlooked, sometimes because the partner is the problem, but sometimes partners are part of the solution. And couples therapy, where you've got groups who are maybe codependent, can be really helpful for both of them to navigate whether that relationship can be utilized for good, or ultimately whether for one or both of them it's going to be a barrier to people moving forward. So I said I spend lots of time in prison, which is a grim place to be. And clearly there are quite a lot of drugs in prison. And a lot of people I see are there because they've used drugs. And when I think about treatments for opiate dependence, I mean, in the UK, we've got about 50% of people in treatment. In France, it's 80%. Maybe in Switzerland, Sweden, 60–70%. Other places in Europe, it's like 10–15%. But where in a country like the UK, you have good access, we've still got less than half of the people in treatment for a life-threatening condition. And, I think the reason people aren't in treatment is it's because it's a pain in the arse. People don't understand how it works. We often deliver it at subtherapeutic doses. We don't bother looking at the ADHD, the anxiety, the PTSD, the depression, and God forbid a psychiatrist won't see you because you're using drugs. And sometimes there are punitive regimes. Well, I'm not going to increase your dose, you're still using drugs. And the workforce is not like McDonald's. They differ. And so we've got, I mean, not bad treatment, but my God, we make it difficult and not terribly attractive. And so certainly when I teach clinicians, I ask them to be transparent about their treatment decisions. It's like there should be nothing you're not happy to share with your patients around why you're choosing a treatment, what you think the risks are. Treatment should be transparent. You know, if you're going to decide to give someone unsupervised doses or not, there should be a really clear process for someone understanding, well, why are you doing that? Is it just because you don't like me, the color of my skin, my gender? There needs to be transparency. And then it's about, well, do your patients trust you? Like, people don't trust you because you've got doctor before your name. And a lot of the relationships, I think, across that table are based in bullshit, which is so tiring. So somehow you've got to build a little bit of trust, and that's difficult. And the other bit is it's really important to know, well, what's a meaningful outcome for them? Like, if they didn't want to be injecting every day and they're quite happy to be injecting on a Friday and Saturday and using less crack, and that's where they are, like, okay, good. That's what they wanted from treatment. That's what they're getting. You know what? That's fine. And so, again, through the pilot, when we develop soda, we give people the opportunity to say, well, what do you want from treatment? And I think if we make treatment more attractive up front and tell people what they can expect, more people are going to come into treatment. I think doctors need to let go of the idea they know what's best for their patient. I don't. I think what I do is I go, look, this is what the issue is. These are your options. These are the ones that are acceptable with your diagnosis or risks. What would you like? And honestly, I might think, oh, I think that one's best. But if a patient goes, I'd like that one, that's fine. In the absence of really overwhelming evidence, whatever the patient chooses is best. And that's fine. And you need to give people knowledge. I'm really, really obsessed about not killing people during methadone induction, particularly if they're on pre-gabs or drinking or benzos. But you need to share information with patients so they can make decisions. I mean, most people know if you use a bit of Subutex, buprenorphine within a few hours of using heroin, you clock your bollocks off, so they don't do it. But some people don't. So it's about knowledge. So this was a one page we made to help people understand the difference between methadone, buprenorphine, and depot buprenorphine, but not talking about anything that is very complicated, but about how long for me to get stable, how often do I have to turn up every day, what's the average dose, what happens if I don't take a dose for a day. Simple stuff. And I think we also need to pay more attention talking about medication side effects. You know, dental health care, constipation, sexual dysfunction. But we just don't talk about these things. I'm obsessed by getting people on the right dose of methadone. So I did this YouTube video about 7 years ago called Getting Your Dose Right on Methadone. I would have thought it was a fairly smallish audience. It's been seen like almost 90,000 times. And honestly, all I'm doing is going, you shouldn't be waking up in the morning feeling clucky and rubbish. And so, with the support of lots of people, including Matt and EuroNPUD, we developed this thing called Soda, which basically lets people figure out what is the right dose for them. So it's like, ooh, what do you want from treatment? And it asks you 7 quick questions. Does your dose ever get rid of your withdrawal, even just for a few hours? How do you normally feel before your dose? Like a little bit withdrawal-y, a lot withdrawal-y, dreadful. How do you feel after your dose? I think your dose should last you at least 28 hours a day. Who wants to be at the chemist at 9 o'clock every morning? So I want to know how relaxed you feel if you can't get your dose. How you feel after your dose is really important. Because I see a lot of people go, no, I'm on enough. And they go, how do you feel after your dose? And they go, oh yeah, better, more energy, blah, blah, blah. And I go, you're not on enough. You want to ask people about how often do you use on top? If you do use, do you get any feeling from it? And how often are you craving? So you ask these little things. And you also ask this question, which is about people being sedated after their dose, which might mean they're on a bit too much, particularly if you've been on a stable dose for years and maybe your liver starts packing up, you might become methadone toxic. And then you get a little score, and the score is 0 to 20. The perfect score is 0, which means you don't have to change your dose at all. And so we plot a score with the smiley face. And for each of the bands, you get some feedback. And again, we changed this after we piloted it. So the original feedback was like, you're using on top, you're in withdrawal, you're craving. So the doctor's going, ooh, you're underdosed. Sounds like you're still using, you should go up. But again, with the feedback from the pilot group, it was like, that might be where that person wants to be. And so for every banding, the feedback also tries to talk from a user's perspective, saying, you know what, if where you are at the moment, controlling your use is all right, that's okay. But hey, be aware of the possibility that shifting your dose might help if you wanted that. And the idea is you get key workers to talk with patients, and ideally, some people go, ooh, I'm underdosed, I feel rubbish, I think I'll go up, and you follow them over time and you see their soda score goes down. And it's been piloted. It shows huge underdosing in the UK, as in lots of other countries. But certainly when we asked patients what they thought, it seemed to make sense to them. So yes, it seemed to accurately assess how stable people were in treatment. It helped people understand how to get the most out of treatment. The scores made sense. But most importantly, 70% said they were going to go and talk to their prescriber. And the whole point of this is to empower patients to have conversations around their treatment. And people do. And amazingly, start off quite well because it helps shift the conversation. And I'll tell you the only is whether they're GPs or nurses who don't like having an informed patient group. And my response to them is, well, sod off. And this is all part of work I'm trying to do, which is just getting people who work in this field to be nice. And, this will be really familiar. Doctor sees patient, he turned up late, he's still using, he's failing, and the patient's going, what? And the patient's going, your treatment shit, I'm not complying, you think I'm rubbish. I mean, this is not useful, but it's common. And all you've got to do is shift the conversation. Hey, sounds like it's a bit difficult to get your dose every day, and some days you're using heroin on top. Is that something that is a problem for you? And when you just offer that without judgment, I think quite a lot of patients go, oh, shit, like, okay. And then I think there can be an explanation about why someone might have withdrawal in the morning, why maybe they're using on top. It's sharing information. And I think we don't use enough of the opportunities that you have to educate people. And I do this all the time. And as long as you say to someone, oh, I'm not quite sure if this is going to work, but, why don't you see if you go up 5, 10, 15 if you feel a bit better? If you do, fine. It's about giving them access to what's going on in your head and giving them options. And so I think opiate substitution treatment has got so much to learn from just being a decent human being, honestly. And the other bit I'd finally say is that I think people are fearful at the start of treatment that they're going to be there forever. So I think you should make a path out really visible at the start. And for me, it's not whether people want to come off, like we know lots of people do. It's about saying to people, is this the right time to come off? Like there's lots of routes off, and we can talk about that in another time, but it's getting someone to think, are things going well in my life? Have I got a crisis coming up? And talking through this sort of decisional balance. I can't stop someone reducing their dose because if they don't want to take their methadone, they won't pick it up or they'll spit a dose out. But you can talk to people. And so ultimately for me, I just want people in my business to be respectful of the people we are paid to help, saying, what would you like from treatment? What's worked in the past? What would make things easier? Is there any stuff you don't know? What medication would you like? And if there's a reason, if I've got a patient who's perpetually diverting their buprenorphine, I'm not going to give it to them, but as much as possible, I want to be able to support what someone tells me they want. And I think that just saying, in the absence of any good evidence, patient choice wins is a really good thing. And so much of this, honestly, just comes down to doing the simple things better. And by doing simple things, I mean being nice and caring and curious, showing you give a shit. We've got medications that are useful, so, use them well. Right doses, right times. And for people who just think, well, what's the point? It's like just being nice to people sometimes makes a real difference. And the other bit that we just forget, and I forget, is that we should be trying to do balanced assessments for people, which doesn't just focus on diagnosing deficits and impairments, but identifying strengths and talents and potential that our patients have got. Because, my God, if you can survive a 15, 20-year-old, heroin habit and ducking and diving, I mean, some of the people I work with are so smart. And it's just giving them the opportunity to do that for, ways that are probably healthier. I shall stop there.
Okay, Adam, thank you so much. You've been wonderful as always. Thank you so much for everything, and you honor us today. Next picture is
Goodbye, guys. It was really lovely seeing you.
Goodbye, Adam. Thank you very much. The next speaker is Professor Manny Mallory. He's a professor of psychiatry, former member of the European Parliament, a long-term contributor to a European drug policy. She led the major reform initiative in Greek addiction services and served on the management board of the European of the EUDA. Mrs. Manny, thank you very much for being here. The floor is yours.
Thank you, Christos. Hello to everyone. Sorry for my voice, first of all. I'm with flu, but I didn't want to miss this discussion. As I told you, Christos, I was very busy recently. I was not in a position to prepare a presentation, but to be honest, I think Adam covered everything in this topic. And it's a pity that he's leaving the discussion, because I was wondering if the first part of his presentation covers not only patients under methadone, substitution treatment facilities, but this is very important for any kind of facility therapeutic approaches to drug addicts. It's general issues. We are discussing for more than 10 years, at least in Europe. But as you know better than me, in our country, Greece, even though the OST treatment facilities had almost 13,000 clients in 2014, and now they have only 6,000, almost 50% less than 10 years ago. Nothing changed in the quality of treatment that they offer. I thought that with less addicts needed OST facilities, the quality will increase. Unfortunately, nothing is happening. We are not prepared even for the new threats, and I mean other substances like cocaine that is increased in Greece, and I don't know. I really don't know if we face any more comorbidity, because a lot of psychiatrists that used to work in OST treatment units are resigned, and this topic maybe is not covered as it was. I really want to congratulate my colleague Adam for his presentation. I hope that it will be possible for us to share the slides, if possible, and I will contribute to the discussion in case there is enough time for it. Thanks for inviting me. Sorry that I'm not in a position to say more. I'm ready to coffin already, but I will listen in silence. Thanks a lot, Christos, once again for inviting me.
It's an honor to have you, Professor Mallory, but you have done so much for Greece. You was 10 years director for art services in Greece, and you were the best director that we ever had. Okay, let's go to the next speaker. Is Elisa, scientific analysis. Elisa Kusevich Ramon, scientific analysis, health and social responses and harm reduction from EUDA. Her roots is from Russian Harm Reduction Association. Elisa has championed the rights-based drug policy across 29 countries, especially around new psychoactive substances and peer-led advocacy. Elisa, the floor is yours.
Hello, everyone. Thank you very much, Christos, first of all, and EuroNPUD for the invitation and for the ongoing leadership in advancing OAT in Europe, for bringing, I think, this urgent topic, because from the already what was said by the speakers, also by the data and insights which I will share, you will see that women and OAT topic is really not covered very well. And as I mentioned, today I will focus on some data, specific key issues related to women who use drugs, and also about the responses, like how we can respond to all these existing gaps. Let me see. Okay, so first of all, I will start with the current situation in Europe, just to give some background on what's going on with OAT. So as you can see from the slide, there is around 860,000 high-risk opioid users in the European Union. So overall, it's around 0.3 of the adult population in the European Union. And OAT is received only by almost 60% of those who are in need of this treatment. If we will speak about the coverage of opioid agonist treatment, and I would like to emphasize actually this slide, you can see a very huge differences in different countries. I was asked today speak a little bit more maybe with a focus on the Eastern European countries, so that's why you see also some countries, specifically showed like in the circles, but please, check all other countries. So what I would like to emphasize about the Eastern European countries is that the coverage with opioid agonist treatment is very different in all the countries. For example, you can see the Czechia, which has around 80% of the coverage, while Croatia has around 50%. And then we see loads of Eastern European countries such as Poland, Slovakia, Lithuania, Romania and Latvia, which are below 20 even percentage. Probably it's not a news, but you know that there is a recommendation provided by the WHO experts that the coverage, the recommended coverage should be around 40%. So many countries do not reach even this coverage, like of 40%. At the same time, I think that's a question for us, like, like to discuss, to think about, is this 40% enough, right? Like, should it be the recommendation? Maybe this recommendation given very long time ago by WHO should be reviewed, So that's again, like, I guess, very interesting question to discuss, because 40% was discussed like I know 20 years ago, and now here we are with still so many countries even not reaching this 40%. So going a little bit more in depth and speaking about the gender breakdown, in this slide you can see the number of people receiving opioid agonist treatment. So nothing new again, 20% are females and 80% males. So here we speak about the European Union countries. And I just like to note that this is data from 17 countries, which represents only 27% of all registered clients, right? So please keep in mind that this is not like the representative data of all the countries, only 17. In some studies, women have been found to be more likely to access treatment because of needs arising from pregnancy or parenting, or because women are more willing to seek care. However, there are also so many studies which are showing that women are less likely to seek specialized services than men because of stigma attached to both drug use and, in general, being a woman with a substance use problems. And also I should mention that little information is available on other gender identities, such as transgender or non-binary people who use drugs. But there is some data suggesting that they are also having a significant barriers to accessing healthcare, especially related to the OAT. In this slide, you also can see the opioid agonist treatment clients in Eastern European countries, and here it's a gender breakdown. For example, if we speak about Bulgaria, there is only 18% of female clients. In Croatia, it's only 16%. In Czechia, it's only 30% of female clients. In Hungary, 22%. In Poland, 24%. Almost 26, and in Romania it's 16. So basically this slide represents what I already showed before in the slides, that it's like 20-80 distribution. So in many countries it's like a very similar situation, just in some countries there are like a little bit bigger differences, like Czechia having 30% representation, not 20. So as the topic of today's webinar is about opioid agonist treatment, I thought that it's also useful probably to provide some information about the medications which are used and provided across the Europe. So more than one opioid agonist treatment medication in 2023 was reported by 25 countries. So at least one medication in 25 countries. Then definitely methadone is the most commonly prescribed medication, which was received by more than half of opioid agonist treatment clients across Europe. Another 35% were treated by medications based on buprenorphine, which is the principal medication reported to be used in 9 countries. And then other substances such as slow-release morphine or diacetyl morphine are more rarely prescribed, but they were received by around 10% of opioid agonist clients in Europe. A little bit information and data about the treatment entry. So we will speak about the clients who just like entered for use of heroin and other opioids. So in this slide, clients entering treatment for heroin in Europe. Again, you can see the gender breakdown. So 82% are male, and then only 18% are female. And it's important also to mention that now when I'm speaking about the treatment, we mean any kind of treatment possible for opioid dependence. So it's not necessarily opioid agonist treatment, but any other forms of treatment are also included. So this is a representative data for any kind of treatment for heroin dependency. In this slide, you can also review the client-centering treatment because of opioids use in Eastern European countries by gender breakdown. And I just thought that maybe it's interesting to share some facts about the opioids, which are the most relevant and with the biggest prevalence in the country. So, for example, in Bulgaria, in Croatia, in Romania, Slovakia, Hungary, the most new entrants for treatment, when we speak about women, they were because of opioid use with heroin dependence. So the main substance used by female was heroin. In Estonia, 76% of female clients entering treatment were with fentanyl dependence. So we speak already about some synthetic opioids, right? And then in Lithuania, in Poland, female clients were entering treatment with other opioid dependencies. In this slide, and this is actually the last slide, showing some data, you can see the trends in female clients initiating treatment for opioid use in Eastern European countries. So in some countries, so here by the date, you basically can just see the trends, how year by year, how many women were entering these services. And in some countries, you can see a huge decreases, then again increasing. But all this, I guess, is related a lot with the drug scene, with the changing drug markets as well, right? With public health approaches in countries. So it all depends country by country. So yeah, please just keep in your mind that this is country by country case, and it should be reviewed by country, why there was such a differences in dropout or increase of female clients. I was also asked to speak about the key issues related to women and drug use, but honestly, many of these issues was already covered by Adam. And I know that we are having so many other speakers, so I will just go through it very fast. As Adam mentioned, specific issues which women are facing: stigma, and actually often it's a harsher stigma than men, because women are more seeing as mothers, as caregivers. Usually they are also seen as violating gender norms in many countries. So when it is internalized, this stigma, it can deepen also the feelings of guilt and shame in women. Also socioeconomic barriers. So women who use drugs frequently experience greater financial strain due to lower employment and income. And when the treatment isn't publicly funded or covered by the insurance, for example, the fees can become a barrier to access the treatment, to seek the treatment. Even the simple things such as travel expenses, like travel from one city to another to receive a treatment, also can make access more hard. Social support. So basically, compared with men, women who use drugs may have weaker support networks, partly because they're more likely to come from families which were affected by substance use or have partners who also use drugs. Parenting responsibilities. So among people who are entering treatment, women are more likely to live with their children. Partners who use drugs. So partners drug use can strongly influence women's initiation, continued use, and risk of relapse. But also, as Adam mentioned, it can also become, like a motivation to seek treatment. So it, again, depends like case by case. And if both of partners are going and supporting each other's in all this trip of the treatment, I think that might become like really a powerful tool. Trauma and gender-based violence. So again, women who use drugs report adverse childhood experiences, sexual, physical abuse, and they report it more often than men. And they face also higher rates of adult gender-based violence, which includes also intimate partner violence. Mental health and dual diagnosis. So again, what Adam mentioned, PTSD, anxiety, depression are more prevalent among women who use drugs. But also it is important to say that compared with men, women with comorbidity are more often described as having a primary mental health. And then the drug use is going as like a secondary issue. And then injecting related risks. So women who inject drugs can face higher HIV prevalence, in part due to more frequent sharing of injecting equipment, especially with their intimate partners. They also report trading sex for money or drugs more often and may less power to negotiate the condom use. So what are responses? What we can do around this? So services for women who use drugs work best when they are coordinated, where they are integrated and intentionally gender responsive. So first of all, design matters, even though it will sound very simple, but I guess we should start from very simple things. So the outcomes improve when gender is built into the service model from the start, like location, opening hours, pathways, staffing, including access to female practitioners. So programs can be women only, or they can be also mixed with tailored components. What matters is basically the purposeful, safe, and reachable service. Tone matters as well. So given the high levels of stigma, which was mentioned a lot of times, and trauma-reported services should be welcoming, non-judgmental, trauma-informed, places where women feel physically and emotionally safe. Also, the holistic offers, they perform better, such as health and mental health care, family and social support, and practical help with transport and childcare. Specialized women-only provision has a distinct role, especially for those affected by intimate partner violence, homelessness, or severe dependence. Also, we should mention the trauma-informed practice, but it should recognize trauma, avoid the re-traumatization, and rebuild the safety and self-worth in women. In parallel, there should be the dedicated pathways for LGBTQI+ women to address specific risks such as homophobia, violence, isolation, and also the family conflicts along substance use. For pregnant and parenting women, our guidance is pretty much, I would say, straightforward, going aligned with WHO recommendations that care should be non-discriminatory, confidential, comprehensive, covering substance use, obstetric, gynecological care, family planning, infectious diseases, mental health, social welfare. And on opioid use in pregnancy, basically the main thing is the stability itself. So the opioid agonist treatment, such as methadone, buprenorphine, alongside the psychosocial support, is often indicated. And abrupt withdrawal in pregnancy is generally not advised due to fetal risk. So the evidence supports both medicines, and buprenorphine may be associated with better neonatal outcomes, but women stable on methadone should not routinely switch unless clinically it's necessary. And so basically both substances should be provided and women should continue this treatment. Multidisciplinary programs, so they bring these elements together, such as psychosocial support, parenting and empowerment skills, case management, child care where needed, or even the child-friendly residential options. And very important thing to mention, last week we had like the mental health day. So it's also important to treat the mental health and substance use together. There is a gap still in many countries that these two issues are not treated at the same time, or sometimes one is treated and another is like kind of forgotten or left for other specialists, etc. So too often drug services, mental health and social care, they operate in silos. So shared goals, coordinated pathways are feasible, and they are really effective. And this is especially important given higher prevalence of some mental disorders among women. Then if we speak about prison settings, again, in prison settings, women should have the same adequate access to OAT for the continuation or start opioid agonist treatment in the prisons. And also important to mention about the release, that release should be systematic, such as housing, finances, skills, family connections, rapid linkage to community treatment. So if a person started in prison, they should be linked to the community center so they can continue that treatment in freedom. Cultural competence also improves the engagement, because we are seeing now the situation that women are not that much engaged in OAT. But it might be also of cultural differences. So the outreach workers who act as cultural mediators, interpreter services, and language appropriate materials, all are very helpful in this. Also, speaking about the digital spaces, we have online counseling, self-guided tools, especially after COVID, all this evolved. So it also can extend the reach and reach women who are not in the services. Okay, and I would like just to present a few more initiatives which are led by by our institution, so European Union Drugs Agency. So one of the initiatives was actually the mini guide. So it's actually one of a larger set of health and social responses to drug problems, a European guide. So this mini guide is just part of this huge European guide, and it basically provides an overview of the most important aspects to consider when planning or delivering health and social responses for women who use drugs, reviews the availability, effectiveness of the responses, and also it considers implications for policy and practice. So this is really a great tool, I think, to begin with in order to improve the services for women who use drugs. And another project which I really want to mention is led by my colleague Lucas Wiesing. It's Optimus, Opioid Treatment Outcomes Interview for Maintenance Medications Users. So it's basically a very big project which is trying to improve OAT care and treatment by implementing consensus guidance on OAT outcomes, monitoring that is service user reported. So basically the people who are on OAT, they are reporting about like on some indicators. There was established the international group of 110 substance use specialists in 32 countries, including like service providers, researchers, people with lived experience in the opioid agonist treatment, and they produced draft guidance over multiple meetings. Afterwards, like this guidance included a service user reported OAT outcomes questionnaire, which is based on the 26 core questions, plus few optional questions in 6 domains, such as treatment, physical health, mental health, social functioning, substance use, quality of life. So basically, the aim is just to give these questions and ask OAT patients just to answer whether the OAT is improving their life from different perspectives, like treatment, physical health, mental health, social functioning, substance use, quality of life. So now we are undergoing the feasibility testing, collecting these cases. So if anyone will be interested in this project, it's still ongoing. Please let us know, or if you are doing it, we are very happy. So yeah, just please share within your networks. Maybe more countries and more services would like to do it. And here, it's just important to mention that OAT saves lives. There is already a compelling evidence that uninterrupted and adequately dosed OAMT, so again, we are coming back to the question of doses, strongly reduces the risk of death in people who use opioids. So when we speak about OAT, it is necessary to say that it's not only improving the life, but also it saves lives. And this is my actually last slide. If I have a few minutes, I would like just to go through it. So during this Optimus project, 10 key principles were developed. And I would call it even not probably the principles, but even something like 10 commandments, which are so important and crucial when we speak about OAT provision. So first of all, make it easy to get. So effective opioid agonist treatment should be simple to access. No waiting lists, no delay after assessment, no rule to stop using drugs at all, at little or better even no cost at all. And services should be open at convenient times. Don't force long interviews. Avoid police involvement, and should be also available in prisons and other closed settings. So it matters because people start, they stay in care when the door is open. And when the door is closed, unfortunately, people can drop off. The second one is treat people with respect. So everyone should be met without stigma. There should be a confidential way to give a feedback or complain, ideally to someone who isn't the manager. And people should be able to switch providers if they want to. If they don't, agree with one doctor, they should be able to switch to another doctor. It matters because respect builds trust, and actually trust is something what keeps people in care. Think long-term, not quick fixes. So for most people, OAT should be continuous and long-term. Detox or stopping medication should only happen through shared decision-making with realistic expectations, with support like counseling if the person wants it. And it matters because, as I mentioned already, stability saves lives, but the rushed tapers, they risk the relapse. 4 is that be dose to effect, not to ideology. So doses should follow WHO guidance and be tailored to each person's needs and preferences. Too low doses don't work, and they also can lead to the relapse. It matters that the right dose prevents withdrawal, craving, and even the overdose. Offer whole person care on site. So general health and social support, they should be part of the services. There should be nurses, psychologists, access to clinician, and easy referrals to any other specialists needed. Most people need more than medication to do well. So it's not enough just to provide medication, but also like this human touch also is a very important component. Use drug testing to help, not to punish. So again, urine drug tests, they should be mainly for initial assessment or when they can improve the safety or treatment. And a positive test never should lead to punishment or discharge from the program. It matters because, again, the care should reduce harm and not create a fear. Measure what really matters, health and life quality. So regular reviews should look at health, well-being, housing, work, relationships, not just the substance use. The full abstinence from all opioids is not the only goal, and reducing the harmful use is already a very valid success, actually. It matters because people seek a better life, not just, be clean or something like that. So the eighth one is designed for those with extra barriers, so providing dedicated options for women, including separate spaces, hours, maybe sometimes even locations, and for people with added needs like parents, caregivers, LGBTQI plus people, young, older people, migrants, minorities, etc. So equity means tailoring the service, but not the person. Connect the dots across services, building strong routine links with harm reduction programs, hospitals and emergency care, primary care, and where relevant, police and justice services to ensure the smooth transition with no gaps. And the last one is learn and improve continuously. So monitoring outcomes and analyzing data, ideally with universities, people with lived experiences, to see what works and what should be improved. Services need also the funding and capacity to evaluate their own programs. So it matters because the ongoing learning, it just turns the good practice into very good results. So in short, effective OAT should be accessible, it should be respectful, better if it's individualized, integrated with the wider health and social system, and measured not only by the abstinence, but by safer and healthier lives of people who use drugs. So thank you very much. Yeah, thank you very much. I'm stopping.
Thank you very much, Lisa. This was very wonderful that we hear from you all these updates from the EUDA. I didn't know about the team, and a lot of things was new to us. Thank you for all the updates, and I'll definitely come back to you to give me the presentation to share with all the team, and because of very interesting stuff is happening there. So I'm going to say to the next, I'm going to go to the next speaker, and please keep the time because the link is going to fall down after half an hour. So next speaker is Kasia Urbaniak. It's a peer advocate from Poland, a strong voice of women's rights and environment with health and social services. Kasia will share her living experience and her life that affected me on the services. The floor is yours, Kasia.
Hello, everyone. Can you see my presentation already?
Yeah.
Or is it fantastic? So, yeah, so as Christos mentioned, my name is Kaś. I use pronouns they, them, and I am a late diagnosed neurodivergent, and I have lived, or rather living experience with opioid agonist treatment. However, my experience falls outside the current official system in Poland. I'm also a peer activist working with the Polish network of people who use drugs, and I am currently completing my master's degree in bioethics, focusing on ethics of harm reduction. First, I will present you a quick overview of my presentation. First, I will share some data on the availability and coverage of OAT in Poland, which Elisa already said something about it, but I will try to develop to dive more. So that we all know the basics of the current situation of the so-called substitution treatment in Poland. Next, I will share some remarks on non-acceptability of the current treatment system, and then I will try to focus on the situation of minority groups, especially women and migrants and refugees, and then infectious diseases and Yeah, and in the end, I will offer some concluding remarks. So, coverage. You already saw this picture. It is a copy from the latest EUDA report. So in Poland, no more than 20% of people with opioid use disorder are currently enrolled in OAT services, which falls well below the WHO target of 40%. The population of people with problematic opioid use was estimated at about 15,000 in 2014, and this is the most recent data, which is a problem in itself. And another problem is that I highly doubt the accuracy of this estimate, especially since it doesn't include the migrant population. Yeah, so the accessibility is also extremely low. As you can see, most patients, OAT patients, are located in Warsaw. It's more than, or about a half of them. And all the remaining patients are spread across several larger cities, which with about one clinic per city. In Warsaw, on the other hand, there are 6 or 7 clinics at the moment, so people can choose a clinic that serves them best, or change the place they get the treatment. And as of 2025, so currently, there are still vast areas of Poland where there isn't any access to OAT. So, why is the current situation so bad? My response to this question would be that OAT is not regarded as a vital, evidence-based public health measure that is a life-saving that is a life-saving treatment. We all know it is. Instead, it still functions as a means of punitive control over the opioid using population. So I would call it a form of coercive care. What's more, the outdated and highly restrictive regulations from the Ministry of Health lead to or create a centralized clinic system with low availability, accessibility, low quality, and non-acceptable for many people. Regarding the non-acceptability of the current system, there are no evidence-based guidelines that I know, but they don't exist. Instead, there is a one-size-fits-all approach with probably more than 90% or about 90% of patients on methadone. Very few people can even get access to buprenorphine. It's very, very strict, very, very, like, there's just one model and that's it. The current system disregards patients' rights. So there is there is lack of informed consent, which is unacceptable and should be unacceptable today, as well as some privacy violations. For example, mandatory urine tests observed by clinic staff, which have to like once a few months, every person needs to be tested. There are also very restrictive regulations concerning take-home doses. So some opioid users, and including myself, decide not to engage with the current Polish system. And if they decide not to engage, but still they need or want OAT medications, there are basically two options for them. So one is getting buprenorphine from a pharmacy, which is technically possible, and I am obtaining it this way. But there's a gray area. It is not exactly illegal to prescribe buprenorphine outside clinics. However, very few providers are willing to prescribe. So it is very difficult to find a doctor who could be interested, could help. And the cost of treatment is quite high this way. Others need to buy the so-called diverted medications from OAT patients. Yeah, so I was asked to focus on the minority groups, on women, and I added migrants and refugees. As Elisa mentioned earlier, women make up about 25% of people of people on OAT in Poland. However, the only policy that I know of explicitly concerning women states that pregnant women should have priority for admission for a program. So, and at least in theory. However, stigma and strict regulations around, for example, around take-home doses, create significant barriers to care, especially for those who are mothers or primary caretakers, and who need flexibility in their life or cannot get to the clinic every morning and get their meds. And in short, there are at the moment there are no specific policies addressing women's needs. And the same with migrants and refugees. In Poland, it is safe to say that there is a quite large migrant population of people who use opioids. So those are mostly people from Eastern Europe. However, there is no precise estimate how large is this group. But it is safe to say that after the full-scale Russian invasion of Ukraine, this group got even bigger. For migrants and refugees, there are several considerable barriers to care, and those include their legal status, language barriers. Most like OAT clinics staff cannot speak any language but Polish. Complex admission procedures, and much more. However, you won't probably be surprised to know that there is no research data regarding the situation of these groups at the moment, so we basically don't know. As for bloodborne infections, it is recognized as one of the main objectives of OAT in Poland that it is made in place to prevent bloodborne diseases in theory. However, apart from providing medications, clinics, I said usually, but I never heard of any clinic that offered testing for HIV or Hep C, or even education. On the other hand, the ARV treatment is only accessible through a quite similar and also centralized network of clinics, the specialized clinics. Also, harm reduction supplies or like needle exchange or even naloxone are simply not available at OAT clinics. In fact, patients who use drugs may face involuntary discharge from treatment. Like if they are tested and the drug tests show that they use anything like not necessarily other opioids, even though that is true. That is also true, but they can be discharged for using other substances. So regarding this objective of OAT in Poland, I would say that it doesn't work, or it is far from like working in a good way. So to conclude, first, so to make the situation in Poland better, first we must acknowledge that people who use drugs' rights are human rights. Then we need decriminalization, destigmatization, and inclusion. And they are they are all needed and necessary to establish high quality OAT services. OAT should be, has to be decentralized, accessible to everyone, offer personalized patient-centered care with shared decision-making, regard for autonomy of the patients, and so on, and be integrated within primary healthcare. And last, in my view, the clinic system, the current clinic system in Poland, cannot be something that can be, isn't something that can be simply fixed. It must be built from the ground up. So basically, we need a revolution in care. Thank you.
Thank you very much, Kasia. I want to say to everybody that I admire the Polish care, the Polish women. They are very brave, and they are doing a wonderful job. And I hope this presentation that we hear from you triggers some things in EUDA to see the situation, what's happening in Eastern European countries. The last speaker tonight, thank you very much, Kas, for everything. And the last speaker for tonight was Matt. Matt Southwell, Managing and Technical Director of Quack Technical Support, Harm Reduction Pioneer, and one of the founding figures of EuroNPUD. Matt, we conclude. Matt, he kind of wrap up what everything he heard from all the speakers, and he tell us about his position in the WHO and what is the recommendations. Matt, the floor is yours.
Perfect. Look, thank you all for a really
Oh, South Africa.
interesting
Oh my God.
webinar. Really accept of OAT as I work in Pretoria at the moment. I'm going to turn my camera off just so that people can hear me. I'm working in Pretoria at the moment, hearing people on OAT, really struggling to have OAT, living in really desperate situations, and it reminds me of what a life-saving intervention it is. We're right to fight for it to be more humane, for it to be more responsive, and for it to be more tailored to our needs. We have a very unique opportunity coming up for us with the new WHO guidelines on opiate agonist maintenance treatment and opioid overdose management coming up. The meeting has just been approved to go ahead in January, and there are two community members, myself and Sean Shelley, who will both be sitting on the guideline development group. We've already been contributing to the development work in terms of some of the surveys. And Eliza, the work you've been doing on the quality standards, I think, are a really powerful tool that we can take into the WHO guidelines and try and embed the work from the Adelphi study in the WHO guidance. It's just the sort of hard data that we need. So thank you very much. It's really helpful. And congratulations, Kaz. Really powerful to hear the work that you're doing in Poland. No, keep up the fight. No, we only get things better by fighting for it. So really, stand strong, and we're all behind you. Thank you, team. Really great work.
Thank you, Matt. Thank you. The connection is not very good, but since you came so far away from thousands of kilometers away and for our webinar, it's very honored for us. So now we have a few minutes to make a discussion. Sarah, we make a discussion. I wanted to ask Elisa first, if I'm allowed it, that if the EUDA associates I know for sure that people from InWAT services are taking from European funds to get better the services, to be better. Is there any kind of control from EUDA what they are doing with those money? Are they getting any better services? Are they doing the spending in the right? Like they said in the application, are they spending the money like they should? Because here in Greece, the last time, I know that the water services took 20 million from the European Union to get better services for the people, for their clients, but nothing came to the ground. Nothing at all, even nothing changed. That's my... Yes.
Yeah, thank you, Christos, for your question. I think it's very important, the question of the accountability of those who are like implementing the projects, especially from the funds of the European Union. At the same time, it's a pretty complex question. And like what can I say is that EUDA definitely is not like, is not the audit organization. So we are not like reviewing like how the money was spent, etc. These are like different organizations, institutions which are following on this. But if speaking about the like quality of services, right? So for example, if the money were used to improve like systems, to, I don't know, integrate new approaches, etc., I think this is something for us, for our future, like to discuss. Currently, we just kick off the meeting of the EU Quality Project, where we are planning to develop basically the EU Quality system, where we will be able to evaluate, like, for example, harm reduction services, like different services or treatment services, So we are just starting this project, and civil society will be involved. We are also planning to do advisory board, etc. But this is I see it as a future, but we want to have this one, let's say, universal system of evaluating the services, which all the countries could do, and then we could see, like the differences, the gaps, the investments, etc. So yeah, as for now, I can just respond like this.
So if anybody has any other question and something to discuss, now is the time, because the time is already past a lot. Hello, is there anyone?
Yes, I'm raising my hand.
Oh, okay, Justina.
Yes. Okay. Yeah. Okay. Hi, everyone. I was listening to these great presentations, and thank you very much for all of them. And as I wrote also in the chat, it was very inspiring and heartbreaking at the same time. So a lot of emotions. I will follow Christos, and I will have a question for Elisa. I know that you probably cannot answer, but this is like me advocating for Poland. Can you actually push member countries, or at least Poland, to have better data? Because I think that we are dealing with a lot. Kasia was also showing that in her presentation, and we miss a lot of data when it comes to people who use opioids or in treatment. And we are doing what we can here, but without the support of the governmental bodies, institutions, it's very hard to do solid research that can give us data, and then we can maybe start a new conversation about new opening for the OAT in Poland. Thank you so much.
Thanks a lot, Justina, for your question. Also nice to seeing you. So as for the data, I would say this. So basically, government should provide it. The question is, I guess, laying in the aspect whether they are doing any, for example, surveillances, like whatever, to have that data. So that's also, like a question, because in many countries, the existing data is basically outdated, right? Because the countries are not doing, like, for example, HIV prevalence, I know, like in prisons, or like the coverage, like sometimes not counting, but this is like basically the decisions of countries, and we cannot affect it. But what should I say is that in our new mandate, civil society organizations also will be able to actually ask us as EUDA whether we have the data, because the countries are reporting to us. We have national focal points who provide us some data, maybe not everything, like, maybe some, I know, like data which we are requesting. But if we have that data, I think that we would be able to share with you. So if your government is not providing to you, maybe we can somehow address this issue. Maybe we can be, the mediator between you and the government in providing data if it exists. Because again, as I mentioned, like some data, it just even us, we don't have it, So it just depends basically on country by country case. Yeah.
Yeah, that's very interesting. Any other one? Any questions? Nothing? So we have to close. Thank you so much, everybody who can be here tonight. It was really very interesting. which we have a future in what the literacy and rights team from EuroNPUD. And I wish we can be more close to EUDA and have more connection with the European partners and the countries, close this gap from Eastern to the Western countries. Thank you all. You've been wonderful.
Thank you, Christos. Thank you, our EuroNPUD team, for organizing this webinar. Thank you, all
Goodbye.
the speakers. Bye-bye.